it's Macy and welcome back to my channel where I share my medical school journey. For today's video, I will be sharing with you a very important skill that I have learned, and that is inserting a chest tube. Indications for chest tube insertion include pneumothorax, hemothorax, pneumohemothorax, empyema, and subcutaneous emphysema of the chest wall in a patient who has sustained chest wall trauma requiring ventilator support or general anesthesia. Before we begin the procedure, it is important that we introduce ourselves to the patient, obtain consent, prepare the materials needed, do proper drapings, and prepare the anesthesia. In preparing the anesthesia, lidocaine is given as 5 mg per kilogram, while lidocaine with epinephrine is given as 7 mg per kilogram. Shown is a sample computation for a 50 kg patient. Materials needed: scalpel with blade, tissue forceps, scissors, needle holder, Kelly forceps, syringe prepared with local anesthetic, sutures, sterile sponges, towel clips, plaster, sterile gowns, chest tube, povidone iodine, sterile surgical gloves, and glass bottle drainage system. Start by positioning the patient in a semi-upright position with the arm placed above the head. This is to facilitate placement by opening the rib spaces and to assist with landmark identification. Next is to prep the skin over a wide area of the chest wall with povidone iodine. Do this in outward concentric circles using the sternum, subcostal area, posterior axillary line, and clavicles as landmarks. Drape the area with 4 towels. Place the first towel on the side nearest the surgeon, followed by the cephalad and caudal positions. The last towel is placed on the lateral side opposite the surgeon. Secure with towel clips. In this video, I'm using binder clips as alternatives. To locate the site of insertion, use the angle of Louis which corresponds to the second rib as a point to localize the intercostal spaces. Slide your finger down to locate the second intercostal space until you reach the 4th or 5th intercostal space at the anterior axillary line. At the 4th or 5th intercostal space, anterior axillary line, infiltrate the skin with a local anesthetic and block the intercostal nerve branches. Do not forget to infiltrate the pleura. Make a 2.5 to 3 cm incision well into the subcutaneous tissue. Insert a curved Mayo scissors or curved Kelly clamp and cut or separate the tissues so as to create a tunnel or track in the direction in which the tube is to be inserted. This track should be directed posteriorly, cephalad, and medially so that the tube lies posteriorly in the paravertebral gutter. Continue this track all the way into the pleura. Remove the scissors or clamp and explore the track with a gloved finger from time to time to make sure the track is going in the right direction. After the pleural cavity has been entered, insert the gloved finger to explore for adherent lung and further enlarge the opening by inserting a large Kelly clamp and spreading it. Grasp the tip of the tube with a long Kelly clamp so that the long axis of the clamp is almost parallel to the long axis of the tube. If hemothorax is suspected, it is also advisable to clamp the very distal end of the tube to avoid making a mess. Insert the tube into the chest using the large Kelly clamp as a guide, either apically or basally. Apical chest tubes are suited for draining air, while basal chest tubes are suited for draining fluid. Palpate to ensure that the tube has entered the chest. Suture the tube to the skin with Silk O. Tie the suture in place by doing a square knot and tight knot. Then, wrap both ends in opposite directions around the tube to make a series of X's. Push the suture down to secure them to skin stitch. Connect the tube to the underwater seal chest drainage system. Care should be taken to do this step properly, as this may cause pneumothorax if tube is disconnected from the underwater seal. Shown is the chest drainage system. In this video, I used a plastic container as an alternative. Place a Vaselinized gauze dressing around the tube. Next, cover the tube with two 4x4 gauze with a slit in the center and place them 90 degrees against each other to prevent them from sliding up the tube. Using a plaster, tape them into place. Lastly, dispose of the contaminated materials into their respective receptacles. Obtain a post-tube insertion chest X-ray to check the position of the tube.
And that's the procedure, mi amigas. So join me next time as I share to you more of my medical school journey. So till next time, bye!